Hey folks, we're going to get into SOAP Notes 101, the essentials.
What are SOAP notes? So we use them very commonly in medicine as NPs, physicians, PAs. They're a way for us to organize our diagnostic approach and treatment plan when we're documenting a patient encounter. So the S stands for subjective. That's everything that the patient's reporting to you. O stands for objective. That's any type of diagnostic test result that you're reviewing and anything that you find on physical exam. Assessment is essentially your differential. What have you thought of? What have you ruled out? What have you ruled in? And lastly, P stands for plan. So, what are you going to order potentially? What is the treatment plan? What's the follow up plan? This is where you're documenting emergency precautions, etc. An example that I like to use is approach to syncope, because that's something that we find very commonly in the primary care setting. So again, this is not an exhaustive list of what you're going to include in your documentation, but an example. So under subjective, what I want to uncover in this patient encounter and what I want to document are things like the date that the syncopal episode occurred, the timing, was it witnessed, was there any loss of consciousness, and for how long did that last? Did the patient experience any palpitations prior to the syncopal episode? Was there any chest pain involved, shortness of breath, any head injury? So if they fell, have there been any concern for head injury or other bodily injuries? And then if it is a female patient of childbearing age, when was their last menstrual period? It's possible that they could be pregnant. Continued, I like to use the 4Ps. This is a way for me to differentiate what diagnostic bucket this syncopal episode might be falling under. So for example, P is the prodrome. So what was happening before the syncopal episode happened? Were they experiencing any lightheadedness, blurred vision, nausea, sweating, abdominal pain? The next P would be precipitants. Is there anything that triggered that syncopal episode? So looking for sort of vasovagal triggers. Were they in a warm, crowded environment? Was there pain involved, like getting a medical procedure? Any emotional distress, fear, coughing, laughing, pooping, peeing? Did it happen during exercise? That is a big red flag, folks, if it happens during exercise. Next P is position. Did it happen because they were standing for a super long period of time? Sudden change of position, so looking at orthostatic hypotension. Did it happen supine? That's a red flag if they fainted when they were lying down. Did it happen with shaving or with head turning in a tight collar? That could be a sign of carotid sinus syncope. And lastly, were there any post-event symptoms? Confusion, loss of bladder or bowel control, concern for, seizure, a seizure episode. And then subjective continued, we always include these factors typically on a history. So past medical history, surgical history, family medical history. What medications are they taking? Any new medications in the mix? Do they have any allergies? And do they have any substance use history, previous or current? Things like caffeine, tobacco, cannabis, alcohol, illicit drug use, etc. So moving on to our objective, again, we're gearing what we need to do on physical exam based on our history. So it depends on our pretest probability of disease. We also want to look at prior test results. Have they had previous, cardiac, ECGs, stress tests, echoes, etc.? Any recent blood work that's been done that's relevant? How do they look in general? Are they toxic appearing? Are they well appearing? Consider doing orthostatic vitals for syncopal events. Full cardiac exam, of course, respiratory exam if needed, and then other relevant findings. Do we need to do an abdominal exam, etc.? Next, for our assessment, really we're documenting this is a syncopal episode, and here is my diagnostic approach and my differential. So things to consider with syncope. Was it neurally mediated? These are the buckets that I like to use to tailor my diagnostic approach. In other words, is this a typical vasovagal syncopal episode? Were there prodromal symptoms? Were there environmental stimuli that triggered it? Could it be carotid sinus syncope if it occurred during shaving or head turning? And second bucket would be orthostatic syncope. So is this because they were super dehydrated? There's volume depletion, from vomiting, diarrhea, a sickness. Could it be a medication side effect or potential withdrawal from a medication or substance? or dysautonomia. So do they have diabetes? Are they elderly? Is there Parkinson's disease and other conditions that predispose them to orthostatic syncope? My next bucket, which is the red flag bucket, is cardiac syncope. So are we worried about an arrhythmia, structural disease, right? So did this happen during exercise? Were there palpitations involved? If there was no prodrome or triggers, again, I'm more worried about that presentation. And then how I like to document these especially acute presentations is, what is my most likely diagnosis here and what evidence do I have to back that up? What are the less likely diagnoses that I've thought through, and how have I, in a fairly confident manner, ruled them out? And then what are the must not miss or red flag diagnoses that I've thought through? Do I still have to work those up? Have I ruled them out effectively? You really want to document that you thought through them. So a red flag review would be things like cardiac syncope, suspected seizure with postictal symptoms. Those are two big ones. Again, not an exhaustive list. And then lastly, for our P, we want to be documenting our plan. So this can look like a lot of different things depending on what your patient is presenting with. But here's an example for syncope. So we certainly might be considering labs, ECG, other cardiac testing, whether it be a stress test, echo, etc. We always want to review driving safety when we're seeing a patient with a syncopal episode, of course. We want to create a follow-up plan with that patient, whether it be keeping them in hospital or sending them home with emergency department precautions. Referral plans, so does this person need to be referred to a cardiologist or other specialist? And then anything else that you want to throw in the mix, right? Do we want to review medications, adjust medications, etc.? So this is not an exhaustive list, but things to consider as part of your plan. So this was a whirlwind run through of approach to syncope using a SOAP note example. Again, not an exhaustive list of everything that you include in a syncopal visit, but just an example of how to use the SOAP charting format. All right, guys, definitely consider joining NP Reasoning Masterclass. I have 100 plus customizable charting templates ready for you to use and review in the primary care setting. You'll get access to on-demand diagnostic reasoning and imaging webinars. You'll also get a weekly primary care update newsletter. Really want to help empower the NP community out there. Let's create a strong NP community together. Thanks for listening.